Okay,
Right. Thanks. You're moving.
is it moving?
Yes, we can see your slide
Okay.
move. Okay.
Okay. So yeah, so as I was saying, patients perceive this sound very differently, and it's described quite diversely amongst patients. It can be a buzzing sound, a ringing sound, or even a whooshing type sound. It is a symptom that sometimes requires a multidisciplinary approach in terms of diagnosis and management. And quite interestingly, the majority of patients of suffering from pulsatile tinnitus do actually have a treatable underlying etiology or pathology. It is quite a poorly understood neurotology symptom, and as mentioned, may involve multiple disciplines: ENT, neurology, neurosurgery, as well as psychiatry. And while many of the cases may end up not having management relevant to or require management by ENT surgeons or etiology relevant to ENT surgeon, we are often the patient's first port of call or entry into the healthcare system, as we get a lot of these referrals from the onset. It's quite a debilitating symptom and can have a significant influence on patients' well-being and also their quality of life. And it can be a harbinger of a potentially serious underlying issue, which I'll go through a bit later. So in terms of a contemporary definition of pulsatile tinnitus, it's an auditory perception of sound or noise that's repetitively synchronous to the patient's heartbeat. All other auditory perceptions are considered non-pulsatile, and these are continuous, and these actually carry a very different pathogenesis, etiology, and management, and it isn't what we'll be discussing today. So specifically, pulsatile tinnitus can be classified as being either vascular or non-vascular, and non-vascular can further be classified as something structural or systemic. It can be life-threatening or benign. It can be unilateral or bilateral, although by far it's more commonly asymmetrical, and it can be subjective or objective. So subjective tinnitus is the most common type of pulsatile tinnitus, and this is essentially only heard by the patient. The associated symptoms depend on the cause. If the patient has associated vertigo, for example, you need to consider something like a superior semicircular canal dehiscence or Meniere's disease. If they've got a conductive hearing loss, things like otosclerosis or superior semicircular canal dehiscence. And if they've got a sensorineural hearing loss, then you think of tumors like a vestibular schwannoma, age-related hearing loss, or even noise-induced hearing loss. In objective tinnitus, this is an actual sound produced by the body. So there's a physical explanation for the perceived noise, and it's often due to a vascular process, which could be arterial or venous. It can be due to other physiological sounds. So, for example, muscular contractions, we get an entity called palatal myoclonus, where you get a clicking sound. It could be related to respiration, and this is specifically in patients with a patulous eustachian tube, or venous hum, which is associated with flow murmurs. This type of tinnitus can frequently be perceived by the examiner on auscultation. So what's the clinical impact of pulsatile tinnitus, and why are we speaking about it? Well, according to some studies, about 14% of patients with this symptom actually have an underlying high-risk vascular lesion, which puts them at risk of a stroke. A significant number of patients will have idiopathic intracranial hypertension with associated papillary edema, and which, as we know, if untreated, can lead to permanent visual loss. And the causes of a pulsatile tinnitus, as mentioned, are not always benign. It also has an impact on patients' mental health, and the prevalence of depression amongst tinnitus sufferers is up to 33%. These patients also have a higher rate of suicidal ideation and a much higher rate of suicide than the general population, all of which are significant. There's a website called whooshes.com based on the sound that patients perceive. And this is a patient platform or kind of support group type website where patients suffering from pulsatile tinnitus can share their experiences with how they entered the healthcare system, their frustrations, and also how diagnosis has helped them. And it may be it's a good resource, I think, to share with our patients whilst we are helping them. get to the bottom of this symptom. In terms of pathophysiology, there are several theories. So firstly, vascular turbulence and flow aberrations. So there's altered vascular turbulence or turbulent blood flow, or even AV malformations, which produce audible sound waves, which are then transmitted to the cochlea as they lie in close proximity. You can also get things like vascular anomalies, like persistent pedal artery, which directly transmits a pulsatile signal to the auditory pathway. There's also vascular compression and dehiscence. So any compression of vascular structures, for example, the sigmoid sinuses, or dehiscence of bone overlying these vascular structures, can also enhance the transmission of sound to the auditory system, and this occurs via bone conduction. And then there's the entity of increased vascular demand or volume in those with hyperdynamic circulatory states, for example, anemia, hypothyroidism, and pregnancy, where there's increased blood flow velocity and turbulence, and this amplifies the vascular noise. So this slide just shows the differential diagnosis and how we like to classify it. I thought this was quite a nice classification. So it can be non-vascular or vascular, and under non-vascular, structural or systemic. I won't go through each of them now according to the list, but just be aware that the vascular causes are by far the most common, and in that entity, the venous pathologies are seen most commonly. And most relevant to the ENT surgeon is the temporal osseous abnormalities, which I'll go through a few of in a bit more detail later. But that's not to forget that there are systemic causes, for example, certain medications, myoclonus, as I mentioned earlier, certain vitamin deficiencies, and systemic conditions like anemia or valvular heart disease. So when we see these patients, it's very important, as with any patient actually, to take a very good and thorough history, because this may lead you down the correct or incorrect path in terms of making a diagnosis. So a thorough description of the tinnitus is very important. The onset and progression, was it sudden or was it indolent, the severity of it, and here you can use what they call tinnitus visual analog scales. There's lots available on the internet. Not all of them are validated, but they do help in terms of getting patients' subjective assessment of the problem. Also the loudness, pitch, and how bothersome it is to their lives. The laterality, unilateral, bilateral is important. If there's any associated neurological symptoms, vertigo or headaches, are they on any medication? Any precipitating or exacerbating factors such as head movements? And then it's also important to do an IAH screen, so a screen for idiopathic intracranial hypertension. And this particularly patients who've experienced weight gain, headaches, or visual changes. This is a quality of life assessment, which it's quite a lot, and you may not be able to see all the detail because the image is quite small, but essentially it's just to highlight that there isn't currently a validated quality of life assessment tool for pulsatile tinnitus. So these tinnitus functional indexes are used for tinnitus in general. And this particular tool is validated, reproducible, and it is actually robust enough to track the effects of your treatment. So if the patient has particularly bothersome tinnitus and it's useful, it does take, I guess, quite long in a busy OPD, but it is also very useful in terms of research, which is, I think, where it's mostly used. On examination, so here, very important to look for any focal neurological signs, assess for any visual loss, and then to auscultate for Bruit. So here you want to decide, is this an objective or a subjective tinnitus? And the specific points of auscultation are the neck, the periauricular areas, orbits, as well as the mastoid. There's also certain physical maneuvers that one can do, and this includes compression, rotation, or Valsalva type maneuvers, and this can help you to differentiate between a venous or a non-venous pulsatile tinnitus. Specifically, compression over the IJV or a head turn to the side ipsilateral to the tinnitus. If the tinnitus improves, then you should consider a venous cause. This has been studied quite extensively, and it's found to have a sensitivity and specificity approaching 80 to 90%. And it's a simple thing to do, so well worth doing in a patient in whom you suspect venous vascular pulsatile tinnitus. Very important to do blood pressure, exclude anemia and hypothyroidism, which is easy to exclude on simple blood tests and physical exam. And then also to do a otoscopy. If you see, for example, a vascular or purplish, bluish vascular structure behind the TM, you may have then already made your diagnosis. Audiological testing is very important as well. So we do a complete audiogram, so airborne conduction testing, tympanometry. This may give you an idea if there may be middle ear myoclonus. Acoustic reflexes in patients with otosclerosis really do have the symptom of pulsatile tinnitus, so it does occur, or superior semicircular canal dehiscence. Speech audiometry, and you want to differentiate between conductive and sensory neural hearing loss. In a sensory neural hearing loss, specifically, why? Because it points you in the direction of certain tumors like paragangliomas or schwannoma. And then I specifically wanted to mention this because it is actually fairly common. So you want to investigate for suspected idiopathic intracranial hypertension. It's less than 20% of cases, but it is something you don't want to miss. So just to go over it a bit, this occurs mostly in young obese females, and in all patients with any clinical suspicion according to the modified Dandy criteria, which I've put in the box on the top. These patients you should investigate for, and then may need to be referred for an LP and opening pressures. In this specific kind of pulsatile tinnitus, they have an increase with in the perception of tinnitus with compression of the contralateral jugular vein, and a decrease in the tinnitus with the compression of the ipsilateral jugular vein, and this is as a result of venous flow. A formal neuroophthalmology review is important, and here they need to do fundoscopy to identify any subclinical visual loss, because some patients don't perceive their loss of vision until a point at which it's irreversible, and untreated papilledema can lead to irreversible vision loss in about 10% of these patients. So it's really not something you want to miss, and if suspicious, you want to refer early. So in terms of imaging, there isn't actually any universal consensus on what constitutes the best initial radiographic study in the workup of pulsatile tinnitus, and this is because the differential is so broad and can come from a number of kind of areas. So overall, the imaging that's effective in detecting the cause of pulsatile imaging is effective in detecting a cause of pulsatile tinnitus in about 70% of patients in conjunction with the clinical exam. So majority of patients do actually end up having some form of imaging. CT and MRI have said to have comparable diagnostic yield, although obviously each may be more sensitive to specific etiologies, and as the clinician seeing the patient, you must make that judgment call as to which imaging is more appropriate and will help you more in making your diagnosis. If the initial vascular imaging, for example, CT or MRI is negative or not helpful, and you still suspect a vascular etiology, then at this point, angiography, catheter angiography would be indicated, and patient would need to be referred to kind of a neurovascular interventional radiology unit for that. And it's very important to consider, availability of all these tests, access, and the cost of various imaging based on the suspected diagnosis and the environment you find yourself practicing in. So I'll just go through a few pathologies and their relevant imaging now. These are things that in the literature are most commonly seen, and perhaps what we see most commonly as ENTs. So an aberrant carotid artery and persistent stapedial artery in these images, you can see this is a coronal CT showing a left internal carotid within the hypotympanum, and that's an aberrant course. And on the right-hand side, there's a CT showing a persistent stapedial artery passing through the obturator foramen. So just a little bit more on this. So the aberrant carotid artery enters the middle ear through an enlarged inferior tympanic canaliculus and can traverse the middle ear to enter the horizontal segment of the carotid canal through a dehiscent carotid plate. It may cause a conductive hearing loss due to mass effect on the ossicles. So in this case, an audio would be useful. and it may be associated with a persistent tapedal artery, and then this further contributes to the patient's pulsatile tinnitus. In terms of more pathology, so Petrus carotid aneurysm. So this CT on the left-hand side shows an expansile lesion on the right Petrus carotid canal, and this is an angiogram showing the aneurysm in that specific area. So many of these aneurysms are large and fusiform and believed to be congenital. How they cause is can be radiation injury, anyone who's had trauma to the Petrus apex, or any infections in that area. Otologic manifestations are conductive hearing loss. They can also get a sensory neural hearing loss, and of course pulsatile tinnitus. And in this particular condition, endovascular treatments are the mainstay of management. It's a very difficult to reach area, and if you've got a vascular lesion there, it's most likely safest for that to be managed endovascularly. Venous sinus dehiscence and diverticuli. So on these images, this is an axial on the left-hand side, on the right is a coronal image, and they both show a right sigmoid sinus diverticulum and dehiscence, also involving the mastoid air cells and mastoid cortex. So this is likely the most common identifiable cause for pulsatile tinnitus of venous origin that we are likely to pick up as ENT surgeons as we look at temporal bone CTs daily. The prevalence is quite high, about 25% in symptomatic patients, and dehiscence of a sigmoid sinus can also, as mentioned on the image, erode into the mastoid air cells or cortex, which is important if you're planning your surgery. Glomus tympanicum or paraganglioma. So on the left-hand side is an axial CT showing a soft tissue opacity in the middle ear, and this is sitting on the promontory. And then in the middle, you can see T1 MRI, and this is showing avid enhancement of the lesion. And then this study showed that they did a DSA, and this shows hypervascularity of the lesion, and that kind of confirmed the diagnosis. For us, for our purposes, so this tumor is often apparent on otoscopy as a pulsating, sometimes non-pulsating, but reddish mass visible behind the TM. The role of imaging is to distinguish it from a jugulotympanic paraganglioma. Most of them arise on the cochlear promontory. A CT, uncontrasted CT, is actually adequate for delineating the extent of the tumor. And on MRI, you see avid enhancement and the typical salt and pepper appearance, which we have come to know. Superior semicircular canal dehiscence. So these patients may have more commonly have other symptoms rather than pulsatile tinnitus, but can have pulsatile tinnitus. This particular patient in this image had vertigo, pulsatile tinnitus, as well as hypoacusis and fullness in the right ear, and these are Stenborn partial views, and this shows dehiscence of the canal, of the right semicircular canal, quite clearly. And how these patients get pulsatile tinnitus is that it results from transmission of the normal pulse-related pressure changes from within the cranial cavity to the inner ear as a result of this dehiscence. The best imaging modality is a temporal bone CT. The particular specific views you look or you ask for, you look at are Stenborn partial views. And I won't go into detail about the management, but as we know, it can be conservative or surgical, and surgical management is either plugging, resurfacing, or combination of these. And then, I thought to mention vascular loop syndrome because we fairly often send our patients with asymmetrical sensory neural hearing loss for MRIs to establish a cause, and we sometimes get a report of or see on the images and get a report of vascular loops. These patients may or may not have pulsatile tinnitus, but we're looking at it today in the context of pulsatile tinnitus, and this image shows a vascular structure impinging on the area of the cranial nerve 7 and 8 complex, and this is that structure is a vascular loop. So pulsatile tinnitus can be caused by arterial venous vascular loops and can be accompanied by vertigo as an additional symptom. Impingement on cranial nerve 7 and 8 in the CP angle or within the internal auditory canal is actually best seen on very specialized MRI sequences. And essentially the treatment of this, if patient is symptomatic and it's indicated, would be microvascular decompression. So just to kind of summarize your approach to imaging, I thought to go back to the list of causes or etiology or differential diagnosis. And I thought this was quite a nice way. So into any temporal osseous abnormalities and more the things as ENT surgeons that we're likely to see and manage, a CT temporal bone is the best imaging for these. And for everything else, so some of the structural neoplasms and any of the vascular issues, venous or arterial, MRI, but more specifically MRA is the best imaging modality of choice. So just to move on to kind of general non-surgical management, this is mostly drawn from the literature on non-pulsatile tinnitus. And here things like tinnitus retraining therapy, cognitive behavioral therapy, magnetic therapy, and also psychotherapy and mindfulness have been mentioned. I'll go a bit more into tinnitus retraining therapy on the next slide. Just to go back to idiopathic intracranial hypertension, here in these patients, there's a specific protocol for management, and that includes loss of weight, acetazolamide and furosemide, CSF diversion, and they may even require optic nerve fenestrations. But these patients would have to be kind of either co-managed or referred to a specialist unit. So just a bit more on tinnitus retaining therapy. So this is for patients in whom you haven't identified a treatable cause, obviously. So, or in patients who you've identified a treatable cause and have treated it, but they still got persistent symptoms and there's no further kind of surgical intervention for them. And the purpose of it is that it's actually a well-studied and evidence-based approach that combines sound therapy with directive counseling in order to reduce the perception and also emotional impact of tinnitus for that patient. And it's done over a period of time. The mechanism by which it works, so it's grounded in the theories of neuroplasticity and habituation, and it aims to retrain the patient's brain's response to tinnitus by desensitizing the limbic and autonomic systems, and then also reduce the distress and attention drawn to the tinnitus signal for that particular patient. It essentially comprises two components, counseling and education, as well as sound therapy. And in terms of the outcomes, studies have shown that it can significantly improve patients' habituation and also reduce any tinnitus-related distress and improve their quality of life. So it is well worth referring for patients who you think will benefit. So this brings me to the end, and these are just some of the key messages. So pulsatile tinnitus is a symptom with multiple possible etiologies, and it may involve a number of different disciplines, as mentioned. Interestingly, a specific cause can be found in the majority of patients, so it's important to have awareness of the broad differential that we've gone through, and also have a high index of suspicion. Categorizing the underlying cause of the tinnitus ensures that dangerous kind of the vascular causes are not missed and that patients receive care from the appropriate specialist in a timely manner. Any clinical red flags that you pick up could include any focal neurological symptoms, including cranial nerve palsies, signs of raised intracranial pressure, and objective tinnitus. And in terms of imaging, a CT temporal bone or MRI angiography are the mainstay imaging modalities used. And just to remember that these are often complementary, and patients may end up having more than one. So thank you for your time. That brings me to the end. I hope that was a useful kind of overview. It is a huge topic and also shared with multiple other disciplines, but I think important for us to be aware of. So yeah, thank you.
Thank you very much, Leila, for such a brilliant presentation. Anyone with any comment on the online? Or maybe we can have Lillian to comment on anything you want to say, Lillian.
Thank you very much, Leila, for the presentation. It was quite comprehensive. Mine is just to emphasize on the role of audiometry, especially for the patients that you suspect have pulsatile tinnitus as a result of a third window lesion or an otological lesion. So most of these patients will have pulsatile tinnitus. You suspect a third window lesion like a superior semicircular canal dehiscence or maybe a fistula. Sometimes when you do the audiometry, we find that most of these patients have a suprathreshold bone. So you can just find that they have a low frequency airborne gap that usually narrows in the higher frequencies, and the bone conduction is higher than normal. So these are the patients you can suspect and further on send for the CT. And also the fact that you can also do a simple tuning of tests where you put it on the lateral malleolus and the patient will be able to perceive the bone conduction on the same ear. So if you don't have the MRIs and the CT scans that can take the special views, that can increase your suspicion. Other than that, thank you. And also to emphasize on the role of cognitive behavioral therapy in the management of tinnitus. Most of especially in patients with depression and psychological manifestations, most of their issues stem from what they believe about the tinnitus. And so cognitive behavioral therapy is actually on the forefront when managing tinnitus patients and improving their quality of life. So sometimes some of the difficult patients, it's good to send them for cognitive behavioral therapy. Thank you.
Thank you very much, Leila. Anyone else with any contribution, questions on the chat? Thank you all for attending. We'll see you on our next presentation. Have a good day.
Thanks, everyone. Thanks. Bye.
Bye-bye.